All right, this is just a quick case to get everyone thinking about how this might work in patient care rather than in slides. So I kind of alluded to this one earlier. 50-year-old male with high blood pressure, diabetes, had sudden onset difficulty writing with his right hand. I believe he had a pacemaker, so he couldn't get a MRI. So he had this CT scan of the brain. And to jump to the chase, he has several distal embolic infarcts in the MCA-ACA watershed territory upstream from this lesion here. So this would categorize as a symptomatic carotid stenosis. And of course, the question is, what do we do with this? Put them on blood thinners, send them home, do surgery, do stenting. So that's all the things that we'll get into partly in my block and in other blocks. Looks like someone raised their hand and that flashed up, but I can't see the question. Oh, here, maybe up here. Okay, if anybody knows how I can see that question, someone that raised their hand, I'm happy, I'm all ears. I don't see it in the question and answer section. All right. Sorry if you raise your hand, I don't know how to engage you. And the answer to that question is what is the natural history of these problems? So what happens if you do nothing? And that is, let's understand on the other side is what happens if you intervene, and which one of those would benefit the patient in different situations. So to understand this, there's like some pretty good randomized controlled trials that have become gold standard on how we manage these patients. And those trials were randomized controlled trials, so they had a control arm. So we can look, here we go. Yeah. I'm looking at the chat as well, so if you guys chat with me, I can stop and talk, answer questions. All right. So some of these trials, like one called NASCET, compared best medical therapy to surgical carotid endarterectomy. Same thing with ECST, the European carotid stenosis trial. Asymptomatic trials, ACAS, American trial, European trial, asymptomatic patients with carotid stenosis. So the question is, what do you do with someone that has symptoms and has carotid stenosis, and what do you do with someone that's not symptomatic but has significant carotid stenosis? And so we'll talk a little bit about what to do in those different situations. So for instance, this is the natural history of patients in the NASCET trial who had 70 to 99% stenosis and were symptomatic. In the European trial, 80 to 99%. All right, this is time in months, so up to 2 years here. And this is freedom from ipsilateral stroke. So 100% is good, lower you go is bad. So you can see this is the medical arm here coming down, and this is the treatment arm. So we can get some information about what happens to patients that are medically treated in these symptomatic trials by watching these lines. And you can see the medical arms. The asymptomatic patients did far better with medical therapy than their symptomatic counterparts in the two control groups. So this makes us understand that the natural history, what happens if you do nothing and just treat someone with medical therapy, is far worse for patients that are symptomatic than asymptomatic. So that's a core thing to understand because it informs what we do with treatment. For example, symptomatic strokes. How many people that have had a stroke from it and have a same side carotid stenosis have another stroke? So in the NASCET trial, 13% of patients had a repeat stroke, major ipsilateral stroke at 2 years after randomization. At 13% per year, so 26% total over the 2-year time frame. The European study had 16.2% for any stroke on the same side at 3 years. So their data was a little bit better medical-wise than this one, but 26% in the next 2 years is a very high number. Additionally, when it comes to symptomatic lesions, how risky they are is actually predicted by how narrow the vessel is. And most strokes occur within the first year, even though these studies went out to 2 and 3 years, respectively. So what do we mean by the stroke risk is affected by the degree of stenosis? So this is a table here looking at the severity of stenosis up to 99% from 60% in NASIT, and then the other trials. We'll focus on NASIT for now. You can see as you go higher degree of stenosis, you generally have a higher degree of 2-year stroke rate. And this also holds true in the European studies. But in the asymptomatic study, there was not quite that association found. So this is why the degree of stenosis is a little bit more significant in our minds than in the asymptomatic patients. What is the risk after a TIA or a stroke in symptomatic patients? And so a large number of these strokes actually happen pretty soon after the initial event of a TIA or stroke. You can see about 5% in the first 5 days and up to in the low teens within 30 days of a repeat stroke. So that's why we don't generally send someone that's just had a small stroke from carotid stenosis from the hospital and bring them back and to clinic and then talk to them and then book surgery. They typically get some sort of intervention for stroke prevention in the same hospital stay, and it's for this reason. It's because the highest risk of stroke is early on after your initial symptomatic event. And this looks like when you're going a little bit further on the time horizon, so it looks a little bit more like this. This is the number of strokes saved per 1,000 carotid endarterectomies in patients with 50 to 99% symptomatic stenosis. You can see less than 2 weeks is the most benefit by far. If you wait 3 months, very little benefit. It's like we got a question. So how is the degree of stenosis evaluated is the question. So in NASET, in ACAS, I believe as well, they all had angiographic imaging with a catheter angiogram. In newer studies, they're relaxing this to be CTAs or angiography, and sometimes even MRAs and Doppler, but they make adjustments knowing that often CTAs show higher degree of stenosis than the angiogram does, and so there's an adjustment for that. So the degree of stenosis may be slightly different on a CTA to be included in a trial than on an angiogram. Hopefully that answers your question. All right, so that's symptomatic. So that's a home run to take care of a symptomatic patient with a carotid intervention for stroke prevention. What about asymptomatic patients? What's our evidence? What do we do if you have an asymptomatic patient that turns out has 70% stenosis and then you're in your clinic? So asymptomatic patients in the ACAS, which is the largest asymptomatic intervention randomized control trial to date, is greater than 60% stenosis was what they decided was the degree of stenosis that made you an asymptomatic patient that could be included in the study. The ipsilateral stroke rate in that medical arm, and again, this is back in '95 before we had some of the more advanced medications we have now, the degree of stenosis was 11% over 5 years. I'm sorry, the stroke rate was 11% over 5 years. And that's significant, but it's pretty low. That's barely 2% per year. So this is this group up here that is coming out to 2 years with very little in the way of strokes. In addition, you see that over time, since '85, all the way out here to the mid-2000s, You see that there's like a trend toward decreasing ipsilateral stroke rates in patients with over 50% asymptomatic carcinosis treated medically. And so this, for example, here was ACAS that we just talked about, NASIT, and then as you get closer and closer to current days, seems like the medical arms of these trials, the stroke rate is decreasing in asymptomatic patients. So that informs what we do with asymptomatic patients, because what eventually may happen if medical therapy truly does show to be beneficial at decreasing stroke rate enough, it may actually decrease it to be better than the stroke rate of the surgeries that correct it. So that's something that's actually being investigated currently in a randomized trial.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.